Okay, let's unpack this. Today, we're taking a deep dive into a topic that touches, well, millions of lives around the globe: depression.
Mm.
It's actually the leading cause of disability worldwide. I mean, think about that leading cause of disability.
It's staggering, and the sheer scale our source material lays out is really startling. These slides, based on a psychiatric nursing text, show a lifetime prevalence for what's called major depressive disorder, MDD,
MDD, right.
at 28.2% for the U.S. population.
Yeah.
Just over a quarter of people experiencing it at some point. And 6.7% have it in any given 12-month period.
Right, so it's incredibly common, affecting vast numbers of people right now. And our source makes it clear that depression isn't just one single illness, is it?
No, not at all. It's really an umbrella term.
Okay.
Exactly. It's described as a syndrome, which basically means it's a collection of signs and symptoms that tend to show up together, but, without one single known cause for everyone. The specific depressive disorders might share symptoms, but how they start, how they progress, and how they're treated can be quite different.
Got it. And the source gives us two foundational terms: mood, which is how you feel,
Internally.
and affect, which is your observable response, what others see.
That's right. Affect is what someone else can see on the outside: your facial expression, body language, tone of voice. And it's important to remember that mood and affect don't always line up perfectly in depression. Sometimes they're quite different.
That makes sense. Okay, so our mission here is to take these specific slides you shared and really extract the most important knowledge, the key insights, so you, our listener, can get a solid, well-informed handle on this complex topic. What's the big picture on the scale of this issue, then?
Well, what's fascinating here is not just the high prevalence we mentioned, but the fact that, according to the source, incidence is increasing across all age groups. It's actually becoming more common.
Really, and the data show some really clear differences in who is more likely to experience it. Women are 70% more likely than men to develop depression, according to the source.
Yeah, a significant difference. Though, interestingly, the source also notes that women are more likely to seek formal treatment.
Ah,
Men, on the other hand, tend to self-medicate more often, sometimes using substances or alcohol, perhaps to cope.
that's a crucial distinction for understanding why people might not be getting help, isn't it? There's also a big age disparity.
Absolutely, it's quite stark. Prevalence rates for MDD in 18-29-year-olds are 3 times higher than in adults 60 and older.
Wow.
So that younger adult group is carrying a much heavier burden of diagnosis right now.
Wow, 3 times higher. That's
Yeah.
huge. Okay, so that's the scale. But what happens when depression shows up alongside other health issues? Our sources talk a lot about comorbidities.
Yeah, and this is where we see that depression is rarely isolated. When depressive symptoms are present with other mental health disorders, like, say, anxiety or substance use, the risk of suicide increases significantly.
Right. And it's tied to physical health, too. I saw that stat about hospitalized patients.
Yes, exactly. The source states that anywhere from 5% to 60% of hospitalized patients experience depression, with the average being around 33%, 1 in 3.
1 in 3, wow.
And critically, having depression when you're also dealing with a chronic medical condition is associated with poorer response to the medical treatment for that condition
Right.
and worse overall health outcomes. It really impacts physical recovery directly.
So it's not just a mental health issue, it's intertwined with physical health. And certain medications can even cause depressive symptoms.
They can, yeah. It's something to be aware of. The source lists things like some cardiac and hypertensive medications, steroids, birth controls, sleeping pills, and even some antibiotics and antifungals as having the potential to induce symptoms. That's a vital piece of information for anyone assessing a patient. Could be the medication.
Absolutely. And another common link is chronic pain.
Yes, and it's a really insightful example of that mind-body connection. The source describes it as a reciprocal relationship. Chronic pain can be a cause of depression because it's debilitating, life-limiting.
Makes sense.
And then depression can actually worsen your experience of pain, possibly by changing how your brain processes pain signals. They feed into each other in a really difficult cycle.
That's a powerful insight. Okay, moving from who is affected and what else is affected, let's look at how depression shows up differently depending on your age. Because it does, right?
Absolutely. It
Yeah.
doesn't present the same way at all. For children and adolescents, incidence rates have been climbing. The source gives numbers like 2.5% for children under 12 and nearly 12% for teens aged 12-17 experiencing an MDD episode in a given year. And the relapse rates after recovery are high, up to 70% in children, 50% in teens. That's worrying.
Very. So what does it look like when depression isn't just adult sadness? What should people look out for?
Well, in younger children, it often shows up as irritability, maybe physical complaints like stomach aches or headaches, a decline in schoolwork, or maybe pulling away from friends, social activities. For adolescents, it might be more moodiness, sulking, being grouchy, maybe getting into trouble, expressing feeling misunderstood.
That sounds like classic teenagers sometimes, though.
It can, and that's the challenge, but also social withdrawal or even running away. The source notes that early onset is also linked to starting substance use or other behavioral problems sooner. The key insight here is that it's not always typical sadness. It can look like defiance or physical illness, especially in kids.
That's so important to recognize, especially since teen moodiness is so common. What about older adults? We saw their rates are lower in the general community.
Right, lower in the community but higher in specific settings like home health care or hospitals. And it's crucial to distinguish between clinically significant depressive symptoms and a full MDD diagnosis in this group, as the source points out. They might not meet full criteria, but still be significantly impacted.
Are there different risk factors for older adults?
Yes. Chronic medical conditions and the medications used to treat them are big ones, big risk factors. Symptoms are also often unrecognized, sometimes sadly dismissed as just a normal part of aging.
Yeah, that's concerning. And how does the presentation differ?
Well, sadness itself might be less prominent. Instead, the source lists things like excessive concern with physical health, feeling tired more often, double sleeping, maybe being grumpy or irritable, and, importantly, confusion and attention problems. This last one is a key insight because it can unfortunately be mistaken for the beginnings of dementia.
Oh, wow. That distinction alone could dramatically change someone's care path.
Mm.
Okay, this brings us to the big question. Why? Why does depression happen? The sources dive into predisposing factors and different theories.
Yeah, and it's a really complex picture. The sources highlight that. There's rarely one single why. The primary risk factors listed cover a lot of ground. Having prior episodes of depression, family history of depression or suicide, past suicide attempts, being LGBTQ plus female gender, being age 40 or older, the postpartum period, chronic medical illness, lack of social support, negative or stressful life events, especially early trauma, that's a big one, an active substance use disorder, and a history of sexual abuse. It's a long list.
So a real mix of personal history, life circumstances, biology, identity factors. What about genetics? Is there like a depression gene?
Well, the genetic theory in the source is more nuanced than that. It suggests temperament, sort of your basic emotional style, can be inherited and interacts with the environment.
Okay.
Twin studies are often cited.
Right.
If one identical twin has depression, the other has about a 50% chance. For fraternal twins, it's more like 20%. Family studies show a 2-4 times increased chance if a first-degree relative like a parent or sibling has it.
So there is a genetic link?
There seems to be, but adoption studies complicate the purely genetic idea. Children of depressed parents have similar rates of developing depression, whether they're raised by their biological parents or by non-depressed adopted parents.
Oh, interesting.
So the insight here is that genetics seems to create a vulnerability, maybe a predisposition, but environment plays a huge role in whether that vulnerability actually turns into depression.
That vulnerability plus environment idea is powerful, and that leads us to the biochemical theories, looking at brain chemistry, right?
Exactly. The source discusses changes in receptor neurotransmitter relationships.
Yeah.
Basically how brain chemicals and the parts of cells that receive them interact in specific brain areas linked to mood, behavior, and memory.
Which brain areas are key players here, according to the source?
Well, the limbic system is mentioned as the emotional center. The hypothalamus helps regulate mood. The prefrontal cortex is involved in mood and concentration. And the hippocampus, linked to memory, is associated with those feelings of worthlessness, hopelessness, and guilt often seen in depression.
And the famous neurotransmitters, serotonin or norepinephrine, dopamine, those ones.
Exactly. Serotonin affects things like sleep, appetite, libido, impulse control. Dysfunction there can show up as irritability, low sex drive, appetite changes. Norepinephrine is linked to energy level, concentration, and libido. Low levels are associated with anergia, that profound lack of energy, and anhedonia, that loss of interest or pleasure in things you used to enjoy.
Right, anhedonia.
And dopamine is about reward, motivation, emotional expression, and may be particularly involved in what's called melancholic depression. The source also briefly mentions glutamate, GABA, and acetylcholine play a role too. So the insight is that depression involves actual physical changes in how your brain's messengers and structures are working. It's biological.
So it's not just biological or just environmental, it's a combination. That's where the biopsychosocial theories come in, I assume?
Exactly right. The stress diathesis model is a great example the source gives. It basically says you have a biological vulnerability to the diathesis, which then interacts with environmental or life stressors that trigger the depression. Psychological stress can literally cause neurophysiological changes in the brain.
And the courses provide a really striking example of this with early life trauma.
They do. It's quite powerful. The insight is that early life trauma can lead to a long-term overactivity in the body's stress systems. This constant hyperarousal can actually have neurotoxic effects, damaging effects on nerve cells,
Wow.
and cause the loss of brain cells, particularly in hippocampus, that memory and emotion-linked area we mentioned. Over time, this can overtax and deplete neurotransmitters like norepinephrine and serotonin, potentially causing permanent neuronal damage and making someone much more vulnerable to depression later in life.
That is a profound point. Trauma isn't just a bad memory. It can physically change your brain and predispose you to illness later. That's heavy.
It really underscores how impactful early experiences can be on brain structure and function.
What about the cognitive theory from Aaron Beck? That's pretty well known.
Yes, Beck's theory, which underpins cognitive behavioral therapy, or CBT, suggests that people develop psychological predispositions and acquire certain thought patterns, often negative ones, from early experiences. Under stress, these negative and often irrational thought processes become active, leading to a distorted way of processing information about oneself, the world, and the future.
And this involves his cognitive triad. That's the core of it.
Yes, the core insight of the cognitive triad is this consistently negative pattern of thinking. It involves 1, a negative view of oneself, I'm worthless, I'm inadequate.
Yeah.
2, a pessimistic view of the world, everything is awful, nothing ever works out. And 3, a belief that negative reinforcement or lack of validation will just continue indefinitely into the future. It will always be this way.
That sounds like a really difficult headspace to be in, and the sources list specific types of these distorted thoughts, like thinking errors.
Yeah, they give several examples. Things like filtering, where you only focus on the negative details and ignore the positive. Polarized thinking, seeing things in black and white, all or nothing. Overgeneralization, taking one negative event and seeing it as a never-ending pattern of defeat.
Okay.
Also, jumping to conclusions like mind reading or fortune-telling negatively. Catastrophizing, expecting disaster. Personalization, thinking everything others do or say is some kind of direct personal reaction to you. Then there are control fallacies, feeling externally controlled or responsible for everyone else's feelings. The fallacy of fairness, being overly focused on perceived unfairness. Blaming others or yourself inappropriately. The tyranny of the shoulds, having rigid rules about how you and others should act. Emotional reasoning, I feel it, therefore it must be true. Global labeling, assigning negative traits broadly, and always needing to be right.
Wow, that's a lot of ways thinking can get twisted.
It is. And recognizing these patterns is a cornerstone of cognitive therapy because they constantly reinforce that negative triad to keep the depression going, in a way.
It really does illustrate how someone's internal dialogue can contribute to maintaining depression. Shifting gears slightly, who is actually seeking help? The sources touch on cultural considerations.
Right. The data shows differences in who experiences major depressive episodes. According to 2015 numbers in the source, American Indian Alaskan natives had the highest 12-month prevalence at 8.9%, while Asian individuals had the lowest at 4.1%.
Okay. And the source also mentions LGBTQ plus individuals.
Yes, noting that LGBTQ plus people and those with genital development variations tend to have higher rates, particularly when they are in environments that are not psychologically supportive.
Right.
Which again highlights the impact of social and environmental factors, like stigma or lack of acceptance on mental health.
Definitely. That brings us to the clinical picture. What does depression actually look like to a clinician? The sources describe major depressive disorder, MDD, in detail.
Yeah, the key insight here for MDD is that it involves substantial emotional pain and suffering, leading to significant psychological, social, and occupational disability. It really impairs a person's ability to function in their daily life, to work, maintain relationships, take care of themselves.
And if untreated, how long does an episode typically last?
Well, the source says about 20% might see symptoms decrease within 3 months without treatment, but for the other 80%, it can last up to a year. And a crucial point is that the risk and severity of future episodes increase with each recurrence. It often gets harder each time.
That really emphasizes the importance of seeking treatment. How do clinicians identify MDD? The sources use the SIG AKPS mnemonic. Is that helpful?
Yeah, it's a pretty common and helpful tool for remembering the DSM-5 criteria for MDD. Just a way to keep the main symptoms in mind. It stands for sleep disturbance, either too much or too little, or sad mood.
Okay.
Interest diminished in pleasurable activities, that's the anhedonia we mentioned. Guilt feelings or feelings of worthlessness. Energy decreased or fatigue, that energy.
Right.
Concentration diminished or indecisiveness. Appetite changes, leading to weight changes usually. Psychomotor changes either slow down, what we call retardation, or agitated. And finally, suicidal thoughts or behaviors. You need a certain number of these present for a specific duration for an MDD diagnosis.
That's a clear checklist. How is persistent depressive disorder, PDD, different from MDD?
So, persistent depressive disorder, or PDD, sometimes called dysthymia in the past, is characterized by depressive symptoms that are present for at least 2 years. The key insight is its chronic nature. It's a long-standing, often lower-level depression.
Lower level, okay.
Yeah, it can be hard to distinguish from the person's usual state. They're normal. Symptoms aren't usually as severe as in a major depressive episode, though hospitalization might still be needed if there's suicidal ideation.
So PDD is less intense but lasts much longer, generally.
Often, yes. It's more of a chronic low-grade depression. The source lists additional PDD symptoms like daytime fatigue, functioning below optimal levels consistently, that chronic low-level depressive or irritable mood, lack of motivation, negative or pessimistic thinking, and low self-esteem. It just grinds you down over time.
And the sources briefly list other types, too. Just
Yeah.
acknowledge them.
Yes, they mentioned disruptive mood, dysregulation disorder, mainly in kids, characterized by severe temper outbursts, premenstrual dysphoric disorder, PMDD, and depressive disorders specifically caused by a medical condition or substance medication use. It just reinforces that depression is a broad spectrum, not one single thing.
Okay. Given this complexity, how is depression actually assessed and diagnosed? What tools are used?
Well, the source names several standard assessment tools, questionnaires basically, like the Beck Depression Inventory, the Hamilton Depression Scale, Geriatric Depression Scale, Zung's Self-Rating Scale. Clinicians might use those.
Right.
They specifically highlight 2 screening tools you might encounter more often: the Patient Health Questionnaire, or PHQ-9.
PHQ-9, yeah, I've heard of that.
Yeah, it's a simple 9-question tool, often used in primary care settings like your regular doctor's office, just to screen for potential depression. And the Edinburgh Postnatal Depression Scale, or EPDS, specifically for screening pregnant and postpartum women.
Those sound like practical tools for identifying potential issues early on, but the source emphasizes one assessment above all others for any depressed patient, doesn't it? A critical one.
Absolutely. Unequivocally. Evaluating for suicide and homicide potential is presented as absolutely critical, non-negotiable.
And the statistics they provide are really sobering.
They are. Suicide is the 10th leading cause of death overall in the U.S.,
Mm.
but for younger age groups, it's tragically much higher. The source says it's the 3rd leading cause for ages 10-14 and the 2nd leading cause for ages 15-34.
That second leading cause for 15 to 34-year-olds, that's just incredibly high. Chilling.
It truly highlights the urgency of assessment in those populations. The source also notes demographic trends. 78% of completed suicides are males, and middle-aged adults actually account for the largest proportion overall. And there are ethnic disparities, too, with American Indian Alaska Natives having the highest rates, followed by white non-Hispanics, according to the data presented.
The source provides really practical guidance on how to ask about suicide risk, doesn't it? How to approach it.
Yes, and the insight is to normalize the conversation, make it less taboo. You can start broadly, like, when you feel this depressed, what thoughts go through your mind? Or tell me what being this depressed is like for you.
Kind of opening the door gently.
Exactly. If suicidal ideation is suspected, asking directly but calmly is important. Are you thinking about killing yourself now? Then assessing plan and means. Do you have a plan? Do you have the means to carry it out, like access to weapons or pills?
Right.
And importantly, asking about protective factors. Is there anything that would prevent you from acting on these thoughts? Things like family, responsibility, future hopes. They also include questions for assessing past attempts and, crucially, any potential for harm to others.
And asking directly doesn't put the idea in their head.
No, that's a common myth. The source emphasizes and clinical experience supports that asking directly in a non-judgmental way can actually provide relief. It shows someone cares and isn't afraid to talk about it. It reduces isolation.
It sounds like just having the conversation can be a form of intervention itself. What are the general steps in a thorough depression assessment, according to the source?
Okay, the source lists 6 key steps. 1, always assess risk of suicide or harm first. That's paramount. 2, conduct a thorough medical and neurological exam to rule out physical causes, thyroid problems, vitamin deficiencies, etc.
Okay.
3, take a detailed history of any past depression or other mental health issues. 4, assess the person's support systems, family, friends, community. 5, identify any potential triggers for the current episode, stressors, losses. And 6, complete a full psychosocial assessment, which includes cultural and spiritual beliefs, as these can be sources of strength or conflict.
And the source breaks down specific areas to explore during assessment, right? Like mood and affect, digging deeper there.
Yes. Beyond just asking about sadness, they discuss exploring feelings of worthlessness, that deep feeling of being inadequate, low self-esteem, guilt, which can be intense, involve rumination over past failings, and even become delusional in severe cases. Helplessness, that feeling that everything is just too difficult, being overwhelmed. And hopelessness. The source calls hopelessness a core characteristic of both depression and suicide risk, that negative expectation about the future, feeling like things won't get better, a loss of control.
Helplessness and hopelessness sound related but distinct.
They are. Helplessness is about current capacity. Hopelessness is about future possibility. They also note that anger and irritability are common outcomes of feeling helpless and trapped. Observing affect means looking for things like lack of eye contact, a monotone voice giving minimal answers, maybe frequent sighing, those outward signs.
What about physical signs? The source mentions vegetative signs. What does that mean?
Yeah, vegetative signs is a term used to refer to disturbances in basic bodily functions necessary for supporting life, things that become altered in depression. The source notes that 97% of depressed individuals experience anergia, that profound lack of energy, fatigue.
97%. Wow.
It's almost universal.
Yeah.
This often comes with psychomotor changes. Either psychomotor retardation, meaning movements, speech, and even thinking are noticeably slowed down, like moving through molasses.
Sure.
Or sometimes psychomotor agitation, restlessness, fidgeting, hand-wringing.
Okay.
Impaired personal hygiene is also common, lack of energy or motivation to shower, groom. Other vegetative signs include changes in appetite. The source says 70% have decreased appetite, but increased appetite is common in PDD or atypical depression. Sleep disturbances like insomnia, trouble falling asleep, staying asleep, or early morning waking, or hypersomnia, sleeping too much. And a significant number, 50–75%, report experiencing pain, sometimes even without a clear physical cause. Chronic aches and pains.
So the insight here is that depression is a deeply physical illness too, affecting energy, movement, sleep, appetite, even pain perception.
Absolutely. It really drives home the whole body impact. It's not just in your head.
Definitely not. What about cognition and thought content during the assessment?
Right. Thinking is often slowed, as we mentioned, with psychomotor retardation. Memory and concentration are typically impaired, making it hard to focus, read, follow conversations, or make decisions. People often ruminate, going over and over problems or perceived faults. Problem-solving abilities and judgment are often impaired. And in severe MDD with psychotic features, the source notes that delusional thinking, false, fixed beliefs, or hallucinations may be present.
So the assessment covers everything from immediate safety risk and physical health to emotional state, physical symptoms, and thinking patterns. Based on all this, how do clinicians plan interventions and set goals for treatment?
Well, the source highlights developing a safety plan as a crucial outcome, especially if there's any suicide risk identified. This plan is concrete. It includes identifying warning signs that depression is worsening, reminders of healthy ways to cope that work for the individual, and a list of contacts for support, including crisis lines.
Like a personal emergency plan.
Exactly. For the physical or vegetative signs, goals are tangible. Things like weight gain if appetite was poor, achieving regular bowel activity, getting back to normalized sleep patterns, maybe a return of sexual desire if that was lost. Broader goals involve increasing social interaction and activity, and eventually a return of future planning and hope.
And what principles guide this planning process?
The planning focuses on the specific symptoms the individual is exhibiting. You tailor it. So addressing those physical vegetative signs, problems with concentration, activity level, social interactions, even personal appearance if hygiene suffered. The source emphasizes again that assessing suicide and self-harm risk is ongoing, not a one-time thing.
Constant vigilance.
Yes. Safety is always the highest priority. This includes things like safe medication administration in inpatient settings and patient education about meds, including monitoring side effects, because good management helps adherence, helps people stick with treatment. And a core principle throughout, highlighted in the source, is the importance of building a trusting, supportive nurse-patient or therapist-patient relationship. That relationship itself is therapeutic.
The sources list specific interventions. What about someone who is severely withdrawn or even mute, not talking? How do you help them?
That's a tough situation. For patients who are very withdrawn or mute, the source suggests focusing on making simple environmental observations rather than pushing hard for conversation. I see you ate some of your breakfast, or the sun is out today. Direct questions can actually increase anxiety and frustration if they feel unable to respond. Using simple, concrete words is helpful because their thinking is likely slowed. Allowing plenty of silent time for them to potentially respond is necessary. And even if they don't speak much, it's vital to listen for any nonverbal cues or covert messages, and to still directly ask about suicide plans, the source notes. This can provide immense relief and decrease their sense of isolation, even if they don't answer verbally.
Okay.
And critically, avoiding false reassurances like, oh, you'll be fine, or just cheer up, is crucial because it minimizes their profound feelings and reinforces their guilt that they can't just snap out of it.
That makes so much sense. You're meeting them where they are, validating their struggle without pressure. What about interventions for depression more generally?
Well, the sources suggest working with patients collaboratively, helping them question their negative assumptions and beliefs, gently challenging them, and considering alternative explanations. This can help shift their perspective and build hope. Identifying those cognitive distortions we talked about earlier is key,
The thinking errors.
because making those conscious allows people to start changing them. Encouraging activities that can gradually raise self-esteem, perhaps, by practicing problem-solving on small issues, learning coping skills, or trying assertiveness techniques is important for building a sense of capability.
Physical activity comes up here again too, doesn't it? As an intervention.
Yes, definitely. Even brief, enjoyable physical activity, just 10-15 minutes a few times a week, is listed as beneficial. The rationale is it reduces tension, can alleviate symptoms of depression and anxiety, improve self-concept, and may even shift neurochemical balance.
So getting moving helps.
It really seems to. Encouraging supportive relationships is also key to reduce isolation. And providing information or referrals related to spirituality can be important, as many people find strength and comfort in their faith or spiritual beliefs. The source also lists practical interventions for those physical needs. We discussed nutrition support for loss of appetite, strategies for insomnia, assistance with self-care deficits if needed, and managing constipation, which can be a side effect of inactivity or some medications.
There's also a big component of health teaching and promotion, educating the patient.
Absolutely. Psychoeducation is vital. The source outlines 4 main goals for this. 1, providing clear information about symptoms, the impact of depression, warning signs of suicide, and ways to express emotions healthily. 2, educating thoroughly about medications, side effects, benefits, the importance of taking them as prescribed, adherence, when to contact their doctor, and explaining that meds often work best alongside psychotherapy.
Okay.
3, teaching self-help strategies like good diet, sleep hygiene routines, the benefits of exercise, and how to find peer support groups. And 4, directing people to reliable digital resources or informatics like evidence-based online programs, Mood GYM as mentioned, apps or toolkits, empowering people with knowledge and tools.
That's a really comprehensive approach to care, covering all bases. What about more formal treatment modalities? Psychotherapy.
Right. The sources describe various psychotherapies. First-line options, listed meaning those with the strongest evidence base, include CBT, cognitive behavioral therapy, which we touched on. It's often short-term, focuses on changing negative thoughts and behaviors. There's also CBTI, a specific version highly effective for insomnia.
Okay.
Interpersonal therapy, or IPT, is another first-line choice. It focuses specifically on resolving problems in current social relationships and interpersonal functioning. And problem-solving therapy, PST, which helps individuals learn to define specific problems, brainstorm potential solutions, try them out, and evaluate the outcomes. Very practical.
And second line options, maybe if the first ones don't quite work.
These include social skills training, SST, to help people improve their social interactions and build relationships, maybe work on assertiveness. Behavioral activation, BA, is interesting. It focuses specifically on increasing engagement in rewarding or pleasant activities and reducing avoidance behaviors. Kind of get moving, get doing. And psychodynamic therapy, PT, which is often longer term, and aims for insight into underlying, often unconscious conflicts and past experiences that might contribute to depression.
And other therapies mentioned.
Yes, milieu therapy, which is about creating a therapeutic environment, especially important in inpatient settings for acute, severe depression or suicide risk, providing structure and support. Group therapy is valuable for normalizing feelings, getting peer support, sharing coping strategies, and education. And mindfulness-based cognitive therapy, MBCT, which combines elements of CBT with mindfulness practices, show to be effective in preventing relapse, especially for those with recurrent depression.
Okay, a lot of talking therapies. The source mentions psychopharmacology, medication, but doesn't detail specific drugs. It does, however, detail brain stimulation therapies.
Yes, and these are crucial options, particularly for severe or treatment-resistant depression cases where medications and therapy haven't been fully effective. Electroconvulsive therapy, or ECT, is described as a gold standard in those situations. Also for depression, with psychotic features, recurrent self-harm, and sometimes acute mania.
What does ECT actually do? How does it work?
Well, it involves inducing a brief, controlled seizure-like activity in the brain under general anesthesia and with muscle relaxants. The source states this is thought to change brain chemistry, essentially resetting certain neural circuits, though the exact mechanism isn't fully understood.
Okay.
Sessions are typically 2-3 times a week for a course of maybe 6-12 sessions in total. The efficacy rates mentioned in the source for severe depression are very high, like 70-90% remission, often within just 1-2 weeks. It can work quite rapidly when other things haven't.
That's remarkably fast and effective for severe cases. Is it a permanent cure?
The source is clear that it's generally not a permanent cure. Ongoing maintenance ECT sessions might be needed periodically, or continuation with the medication and therapy is usually required to prevent relapse.
Got it. And potential side effects.
Yes, potential adverse reactions listed include temporary effects like post-procedure disorientation, confusion, headache, muscle soreness from the muscle relaxant, sometimes nausea. The main concern often raised is short-term memory impairment, particularly for events occurring around the time of the treatment, although the source suggests this usually resolves.
And are other brain stimulation therapies becoming more common now, alternatives to ECT?
Yes, the field is evolving. Transcranial magnetic stimulation, TMS, is mentioned. It uses magnetic pulses to stimulate specific brain areas. The source notes it has 70-80% effectiveness and is described as quickly replacing ECT in some cases, partly because it doesn't require anesthesia or induce a seizure. Vagus nerve stimulation, VNS, involves an implanted device, like a pacemaker, that sends electrical pulses to the vagus nerve. It's FDA approved as an adjunctive or add-on treatment for long-term treatment-resistant depression. It's thought to affect brain blood flow and neurotransmitter levels like serotonin and norepinephrine. And deep brain stimulation, DBS, is noted as still experimental for depression. It involves surgically implanted electrodes in specific brain regions. It carries more significant risks like brain hemorrhage or infection.
So there are a range of sophisticated physical treatments available when other methods aren't sufficient. That's good to know. Before we wrap up, the sources include an important section on the caregivers themselves, the nurses or therapists.
Yes, this is a really valuable insight, I think. Working closely with depressed patients who can be withdrawn, express feelings of worthlessness, maybe reject help, it can be incredibly challenging emotionally for the caregiver.
I can imagine.
It can lead to feelings of frustration, hopelessness, maybe a sense of ineffectiveness in the care provider, like, am I even helping?
It sounds like the emotional weight of the patient's illness can really impact the caregiver.
Precisely. The source notes that nurses and other caregivers can experience unrealistic expectations for themselves, feel anxious, hurt, angry, helpless, or incompetent. They can even subconsciously begin to mirror or experience the hopelessness and depression of the patients they're caring for. It really highlights the critical need for good clinical supervision, peer support, and self-care for those working in these demanding helping roles. Burnout is a real risk.
That's a crucial reminder for anyone involved in caring for someone with depression, professionally or personally. Finally, how do we measure if treatment is working? How is progress evaluated?
Right, evaluation is key. The source states that short-term indicators like the frequency and intensity of suicidal ideation and self-harm urges are continually assessed. These are immediate safety outcomes, obviously top priority. Then more broadly, measurable outcomes listed for evaluation include the patient's ability to state alternatives to suicidal thoughts, their ability to explore those thoughts and feelings constructively, positive changes in thought content, fewer distortions, more hope, also improvements in self-esteem, increased social interactions, and ensuring basic physical needs, like activities of daily living, ADLs, hygiene, eating are being met consistently.
That gives a clear roadmap for recovery, connecting back nicely to the initial assessment points.
Exactly. It shows that evaluation looks at both immediate safety and longer-term improvements across multiple domains of functioning mood, thoughts, behavior, physical health, social connection.
Well, we've taken a truly comprehensive deep dive into understanding depression based on this detailed source material. We've explored its widespread impact, the many factors contributing to it, biological, psychological, social, how it looks different across ages, the vital steps in assessment, especially assessing risk, and the wide array of interventions and treatments available, from therapy to medication to brain stimulation.
And I think the key insight woven throughout these slides is that depression is such a complex, multifaceted condition. It's not just a feeling, it's an illness, deeply influenced by this intricate interplay of biological vulnerabilities, learned psychological patterns, and our social circumstances and stressors. Understanding its varied presentations, the nuances of assessment, and the range of available therapies isn't just helpful, it feels essential for making a real difference.
Absolutely. It's clear there's no single cause or simple fix, which leads to a final thought, perhaps. Given how interconnected everything seems, biology, past experiences, our current thought patterns, our social support systems, how all these things weave together in contributing to depression. What does this incredible web of factors tell us about the most effective paths toward healing and building resilience? Not just for individuals struggling, but maybe for our communities as a whole.
That's a powerful question to leave our listeners with.